Dr. Michael as well?
Sure. So it's my pleasure to introduce Dr. Michael Klein, who's Associate Professor at NYU Langone, and has an interesting case for us to discuss and see what the panelists think.
Thank you so much. Good morning, or I should say good afternoon, everybody. Thank you very much for the invitation. Thanks to both AAST and Pan American Trauma Society for having me. Let me see if I can share my screen here. I should be set up to do it. All right. How's that?
Perfect.
All right. So we're going to present a case today of a penetrating injury to probably one of the more harrowing regions of the body that we see. So this is a penetrating injury to the surgical sole. I don't know if I need a disclosure slide, but I have no conflicts of interest related to this anyway. We're going to start this case actually at a referring hospital. So this patient comes in. It's a 42-year-old male brought in by EMS after sustaining a single gunshot wound to the left chest, just below the nipple, with a report of hypotension in the field. So in the trauma bay at the referring hospital, his airway was patent. He was speaking full sentences. He was alert. He was oriented. His breathing was non-labored. Had bilateral breath sounds, but with the report of the hypotension in the field, that sort of theme continued, and they were actually unable to obtain a blood pressure initially, even though the patient was mentating. So they started MTP, and finally, after transfusing a couple of units, they got their first blood pressure, which was 90/60. More importantly, on exam, he did have peritonitis, and he did have a positive FAST with fluid in the right gutter in Morrison's pouch. So continuing on in the trauma bay, because of the hypotension, the expected trajectory of the wound, they did place a left tube thoracostomy, and with that, they did get a large rush of air, and his hemodynamics immediately improved. And they also placed a right femoral introducer. There was no chest X-ray performed, and I'm just going to take a stop to ask what our distinguished panelists think so far, and what next steps they would take.
I think this is certainly reasonable. I would, if you know why, or if you were the practitioner as to why no chest X-ray was performed, because I always worry that if something was in the left chest, it managed to traverse to the right chest as well. And you always hate to be in the circumstance that someone's crashing. It's not in the belly. It's not in the chest. Is it in the right chest?
Yeah, it's a fantastic question. It's actually one of the first questions that I asked too when this patient ended up being transferred to us, which we'll talk about. I think it was a combination of things. I think number one, logistically, I think a system may have been down. I'm not sure about that. But number two, the practitioners, the practitioners actually that were at the time, were very, very heavily and well trained in ultrasound, and multiple FASTs, which I didn't mention in the slides, but had good lung sliding, particularly on the right, and they figured the left side was treated. So with the continued hypotension, I think the thought was just to get him out to the OR, but obviously I wasn't there. I wasn't part of the decision-making process, so I can't speak for sure.
And that's fair. I would say my ultrasound skills are seldom handy enough to be able to elucidate a large even, and certainly not a moderate or small hemothorax. But I know that there are some who are more skilled in that area.
And I think actually both of you makes a really important point, and thank you, Dr. Klein, for sharing this. And if folks are okay, I'm a very first name basis because we're very much friends here. So if that's okay, Mike.
Not a problem.
And actually just looking at Dr. Grove's comment, Alan says he would always do a chest X-ray. That's fair. I think it depends on how the hemodynamics improved. Do we want to assume that the hemodynamic abnormality was only because of a tension pneumothorax? I want to say no. I like erring on the side of my patient is trying to die in multiple different ways. The most common ways is by bleeding until proven otherwise. We have, interesting challenges at the University of Chicago where it takes us, if we're running, it takes us a good 4 minutes to get to the operating room and 2 elevators and some hallways. So And we know that, you know, if I intervene surgically after 10 minutes of a hypotensive torso trauma patient, mortality rates will go up. So I'm inclined to, what we tend to do here is we don't intubate if the patient's able to ventilate and we're, you know, they're still alive from that perspective. We will head straight up to the OR. He has peritonitis anyway, but I'm going to assume the patient will be hypotensive again from blood loss or anything. You know, we're going to talk about the surgical soul. So spoiler alert, we know what's going to happen next, but I think it's important to get to the OR straight away. I did have a question for you, Mike, about, was there any thought about the right femoral introducer? And if that's the sort of safest site to place that at? Or Carlos, I might hand that back to you, or if the, you know, if folks want to discuss that. Sorry.
I can jump on it first, Carlos, if you don't mind.
No, I agree with Dr. Zackerson. And unlike Dr. Zackerson, I just spent 10 years in the South. And so I'm incapable of calling anyone other than like 5-year-olds by their first names. But so I agree with Dr. Zackerson. I'm hesitant to, without, I'm hesitant to infuse large volumes into the femoral vessels in somebody who has a below the diaphragm torso trauma with positive FAST, because my assumption is going to be everything I pour into them is going to go into their peritoneal cavity from their lacerated iliacs. But that's my.
Yeah, I agree, and I think it's one of those things that we always like to teach our residents and our fellows, is that certainly if you think that there's major bleeding somewhere in the belly, not, you know, to try to avoid that femoral access if at all possible. I think from a logistical standpoint, I think we've all been there when, you know, there's a lot of stuff going on, patients being resuscitated, perhaps there's an air procedure, or the patient's in a C-collar or something else, and there's a lot of activity kind of around the neck and the chest, so you can't necessarily always get that ideal, you know, subclavian. Again, you know, this is at the referring hospital, so I don't want to speak for them per se, but I know that a lot of times I'll go through and I'll teach the residents, you know, you really want to femoral for the reasons that you just mentioned. And then the next patient will come in and of course we'll place a femoral. So sometimes that does happen. But ideally, yeah, when we're going through this case, certainly probably given the fact that the patient already had a left chested, especially, you know, a left subclavian probably would have been a more ideal choice.
Jose made a really interesting comment in the chat.
Oh, I thought the femoral introducer was Archeo preparing for Reboa. Oh, that's interesting. So I can speak for my group. Again, this is not the group that initially took care of this patient at the referring hospital. My group is very split on Reboa. So we're all products of where we train. So where I trained in Pittsburgh, you know, we're not big on doing lots of procedures. A-lines and Reboa is kind of in the trauma bay. But I have partners of mine that are very strong believers in that. So I typically won't do that. I think if you can open an OR fairly quickly, and I think this depends a lot on your setup in your hospital, that kind of thing. But if you can get a patient up to the OR fairly quickly, I'd rather do everything there as opposed to, you know, spending time trying to get a Reboa, things like that in the trauma bay. But that's me.
Great, let's continue.
Mm-hmm.
All right. So, as mentioned, we all know where this is going. So the patient went to the operating room. Right away, they encountered a large hemoperitoneum upon entry. You know, I took out a lot of kind of the standard stuff, you know, the 4-partner packing and all that, which they obviously did. They got to it, and what they found was a left diaphragm injury that they repaired. They found an anterior and a posterior gastric injury that they repaired. And they sort of were following the trajectory of this bullet from the left chest through the left diaphragm, anterior posterior stomach, and sort of found a pancreatic neck injury with an extensive hematoma in the lesser sac. So they performed right medial visceral rotation. They found a hole sort of in the anterolateral wall of D2, D3. Oh, I'm sorry. No, in the lateral wall of D2, and then in the anteromedial wall of D2, D3. No bile staining at the time. They repaired they repaired the lateral wall in 2 layers. Then they performed a methylene blue test via the OG tube, and they found blue staining medial to the duodenum. I'll stop here.
Maria had a question.
Yeah, I did. Thank you. You know, I always care about holes in the pancreas and holes in the duodenum, and I really care about holes in structures behind that. So I'm wondering what they found, where they found the bleeding, extensive surrounding hematoma behind the pancreas. I worry about that hole in the IVC behind that of the pancreas. So I'm wondering, where's that in this narrative, or is that the next slide?
Yeah. So I'll get to the next slide. So that they did not explore the RP that far. They did not cochorize the duodenum. They just did the medial rotation of the colon. And then they went really after the pancreas. So in their mind, the trajectory went sort of anterior posterior stomach, medial wall duodenum, lateral wall duodenum, and then came out. So sort of missed and went anterior to the IVC. So for that reason, I think they didn't explore that.
But sorry, Mike, just to Dr. Crandall's point, I think that's really, really important, because even on the previous slide or the slide, like when we get into an abdominal cavity, it's always like bleeding, bowel, bladder, sort of, you know, your concern. What's going to kill your patient immediately? What can kill your patient, you know, some hours into the future? What can cause significant morbidity, maybe mortality, you know, weeks to months to years in the future? And, you know, bladder goes with diaphragm, that type of thing. But I think, to Dr. Crandall's point, what was the source of the hemoperitoneum that you saw? We're not going to repair the duodenum in 2 layers at this point. We're going to go after what is bleeding. We need to really see that. And I share, Maria, I share the same kind of ill feeling that you share, in terms of we really haven't exposed the vessels that are important, especially to the you know, at this very, very critical anatomic region of the abdomen, where there are a lot of vessels and a lot of other maneuvers that we need to do to identify life-threatening hemorrhage that might be contained, yes, but yeah, I just concur with just to amplify what Dr. Crandall was saying. I think that's really important.
Dr. Mahmood, do you have any additional thoughts?
Hi guys, sorry, I'm joining from the car, which is why I've got my camera off, but I will be stationary in a few minutes. It's 5 p.m, so rush hour traffic and school and work leaving time in the UK. And I missed the early part of the case, but when you were talking about duodenum and duodenum mobilization and retroperitoneal and pancreas, it was bringing me back to a case where we had something similar, and mobilizing the duodenum to get to those vessels at the back. Actually, we managed to deal with what looked like a sort of cave or IVC junctional injury, which we thought was fantastic. But actually, just by mobilizing the duodenum, we downstream, about 2 days later, we had a perforation, because you can easily devascularize the duodenum. There was delayed perf, which ultimately led to the death of our patient on one of our cases a few years ago. So yeah, it's a high risk area. But I agree, it needs to be explored, but ideally with people who are used to being there. In the UK, the system is slightly different, because we don't have dedicated single cavity trauma surgeons you might be aware of. That we actually have upper GI, lower GI, liver specialists. So we have a slight disease of super specialization. And so to deal with a patient like this, I would actually need my upper GI guys, my lower GI, a possibly vascular surgeon on standby. So I'd actually need 2 or 3 surgeons available, which I know seems strange for the US, but that's the way it works here, because our actual penetrating load of trauma is less than 10%. And 90% of what we deal with is blunt, so the mechanism is usually quite different. But that's just my thoughts so far. But I missed the early part of the case, so apologies.
Dr. Mahmood, that was really fascinating, and thank you for that international perspective. That's exactly why I believe one of the reasons that this panel was pulled together. Obviously, we have that would be 10% would be a wildly slow day, maybe in the middle of December here. So it's interesting that you say that, and that therefore experience with these kinds of missile related injuries would be relatively infrequent for surgeons in the UK. Is there, I mean, I guess my question is there additional military training? The opposite is true for here in the US, where during peacetime, we have trauma preparedness and combat readiness residents and faculty rotate with us in civilian trauma centers to get a familiarity with penetrating trauma. I'm wondering how that works in your educational system, and forgive my ignorance.
No, sure. So I mean, we do have the Royal Colleges run regular damage control surgery type courses several times a year, and we expect our guys to stay brushed up. And where I actually work in the UK is the Royal Centre for Defence Medicine. So we're slightly spoiled that we do actually have a lot of people with a trauma focus, but actually a lot of the major trauma centres in the UK don't have that focus. So it is a challenge, and each centre actually does it in a unique way. They've learned to have to adapt their system to the disease. So there are different specialists. So in one centre you might find the lead is by vascular surgery, because that's where the interest is. And in another centre, vascular rarely get involved, and it's all upper GI. So we don't have a universal pathway. We actually have what the centres have done to adapt their processes to accommodate the pathologies they're dealing with, and they've all got hybrid ways of doing it. So it is a very different perspective, but we've all had to learn to
Thank you.
Dr.
deal
Zach,
with.
would you actually have done anything further to evaluate the vessels at this point based on what you've heard, or the right medial visceral rotation and they're not seeing much blood? That would be okay.
Yeah, so you can do that, but I think again, just to repeat what Dr. Crandall already said, is you really want to do like a Cochrise widely. You really want to make sure you've gotten to your left renal vein. You've explored very, very carefully and made sure that your IVC is intact. You want to make sure also your porta hepatis is intact, like your portal vein is intact. And then it gets to the question, which maybe, Randeep, we're getting there if you'd like, is like, what do you do if there's like massive bleeding, which might not be the case here, behind the neck of the pancreas, let's say. It sounds like the trajectory might have been, it could be that, but like, especially bleeding behind the neck of the pancreas, what are you going to do for that? Specifically, if you're worried about SMA, SMV, and your portal vein sort of junction there, what are you going to do to analyze that? But to your point, this in my mind is a damage control case already with the patient coming in. I have to give blood in the trauma bay. They're probably coagulopathic. One thing we like to do here at the University of Chicago, because of a variety of factors, is we have quite a bit of flux in terms of who our anesthesiologists are. So we guide them pretty aggressively to say, please tell me what the base deficit is every 20 minutes and tell me what the temperature is of the patient every 20 minutes to really see. That's assuming they're not hypotensive anymore, not even in class 2 hemorrhagic shock or just tachycardic. Even if they're pristine hemodynamically, we're going to follow them through base deficits. But in this case in particular, I've decided this is going to be a damage control case from the get-go. And that means like, what is bleeding? What is happening here? And I'm going to just if I'm happy that there's no massive bleeding, nothing needs to be controlled on that level, which I'm whip stitching things closed. I'm not doing any intraoperative cholangiograms at this stage. Not spending, too many hours in the OR and just resuscitating. We'll come back another day. And we tend to do our approaches here pretty much staged, just because our patients are quite a bit sicker than what they might be in that window of physiologic normality. But thank you.
Okay, Mike, we should keep going.
Yeah, I think all valid points, and I do want to put a pin in the idea of a Cochraization, because although it wasn't done now, we'll sort of get to it in a couple of slides. Regarding the idea of an intraoperative cholangiogram, certainly in the index operation when a patient is hypotensive, all the things that Tanya brought up, I think are extremely valid. Here, at the referring hospital, they did decide to do one. This is after they looked at the pancreas. They saw a couple of sort of unnamed bleeding vessels that they controlled a couple of clips and packs. And they did decide to do a cholangiogram, which of course the patient became unstable and coagulopathic during it. So they sort of aborted it. They went into, you know, their damage control procedure and brought him back to the ICU. So in the ICU, he's resuscitated, he's stabilized. They're finally able to get some imaging on him. So you see this chest X-ray here. I'm not going to spend too much time on it because we have some more interesting imaging. But you can see that the lungs are up, the left chest tube is nice in place, and there's nothing really else happening above the diaphragm. Below the diaphragm, you can see a couple of drains. You can see, you know, a pack there in the left upper quadrant. They did get a CT here. Hopefully this video works here. Can you all see it?
Yes.
Okay. So I'll just see if I can pause it here just to give you sort of the idea of what's happening. So you can see a bunch of drains. You can see just a massive sort of, you know, swollen loop of bowel there and some fluid around the head of the pancreas and duodenum. And you can see as we go down, you can see that there's a metallic foreign object, presumably the bullet, there in the gutter on the right side. So moving forward. So they resuscitated him in the ICU, they stabilized him, and then they gave us a call at Bellevue because at this point they said, well, this looks like a pretty significant pancreatic duodenal complex injury, something that they couldn't really handle there due to a lack of certain specialty surgeons. So they called us for transfer. So this is just a map of New York City for those of you that are unfamiliar. Bellevue is located right here, sort of at the southern half of Manhattan. And we are one of the, if not the major referral center for trauma patients in the city for the municipal hospital system. So he came to us.
It also kind of looks like the CT of the pancreas you just showed us.
Oh, sorry. Yeah, I guess I like that. that was not on purpose, but I do like that. Maybe I'll use that from now on. So he arrives to Bellevue. He arrived intubated, but he had good gas exchange. He was actually normotensive. He was not on pressors at the time, just mildly tachycardic. The open abdomen with the apthera in place. Only 5 minutes left, so I'm going to move forward. All right, and bilious drains. So next steps, just in one word, and anyone? So we like to take these patients back to the OR almost immediately every time we transfer them from another hospital. We like to look for ourselves. So we immediately took him to the operating room. We saw the gastric apparatus were intact. We know that there was bile pooling between the pancreas and the SMB. Now we co-caused the duodenum to sort of complete that evaluation. We saw that the retroperitoneal major vessels were intact. So now, because the patient was otherwise stable, looked okay, we really want to get a sense of the anatomy. So we did our intraoperative cholangiogram. We found no filling of the duodenum on the first slide here. We gave him glucagon. We put some manual pressure here on the head of the pancreas. We saw that the leak was still present, kind of an unclear source, and the duodenum wasn't filling. And then finally, we really put a pack on the pancreatic head and held tight. That's where you see the ring clamp there. And you see that now there's some vascular contrast in the duodenum. And take my word for it, there's a leak right at the antula here. So next steps here.
This is super interesting. I mean, Whipples are one of those things that we always talk about, but I don't, based on what you're saying, that isn't what I would do here. And usually if people can tolerate a Whipple, they may not have actually needed a Whipple. Sometimes they do, you know, the entire complex is destroyed. But it sounds like you found a leak near the ampulla, but not in the ampulla. So it's entirely possible that an on-table ERCP with decompression and drainage, and then let things sort of simmer down as long as he doesn't get pancreatitis and digest all of the sutures you put in, that might be a really good choice. I am usually a less is more at this stage person unless the entire complex is destroyed.
Yeah, this is the debate that we had, and certainly the reason for transfer was actually for a trauma Whipple. That was actually the request that came from the referring hospital. And we are always very, very hesitant to do that for all the points that you mentioned. Is most patients really don't need it. On-table ERCP was one of the options that we considered, but given the logistics at the time, we actually opted for an MRCP, just to delineate the anatomy a little bit more. And what you see here, I know we have 5 minutes left, so I'm just sort of scrolling through this fairly quickly, but you can see that there's certainly a disruption of the medial duodenum here at the pancreatic head. And the MRCP, was read as the pancreatic duct visualized at the pancreatic head, then disappeared toward the body. So you're right, Dr. Cano. So the ampulla did seem to be intact, at least based on this, but there was some disruption somewhere clearly. So we didn't really have a good answer for that. So knowing this, now what? And I think to Dr. Crandall's point, I think an ERCP is probably indicated. So we took the patient back to the OR for another laparotomy with an ERCP this time. And although they were able to pass the endoscope down, what they found is a large amount of mucosal edema of the duodenum. So they actually weren't able to visualize the ampulla. But there was also no obvious transmural defect identified, and presumably that was because of the edema. So because of that, they couldn't actually perform the ERCP.
So question for you, how much bile was coming out and how was the patient doing?
So the patient was relatively stable within the first 5 days or so, maybe on a couple of mics of norepinephrine, on and off, responsive to volume, but relatively stable. The drains were not pouring out a ton of bile. And certainly when we took him back to the OR that time, we didn't really see any bile accumulating. So whether that was due to sort of, the edema, which is sort of what we thought, we weren't really sure. Clearly there was some injury there. But at that point in the OR, there was not a ton of bile. And I see that Tanya also raised her hand.
Yeah, thanks, Mike. I think I know we're pressed for time. I think one thing that's important in talking about is, it's tricky if you're going to make the decision to do a Whipple procedure. In these trauma patients, we found that the bile is a problem leaking, but I would ask you more, what does the saponification look like? Like, what is the pancreatic burden of leakage? Because that really leads to a lot of localized inflammation. It makes any sort of subsequent surgical anastomoses that you're going to do very, very challenging as the days progress, as we try to control leakage from pancreatic this and that. And it seems like you have a main pancreatic duct injury. So I was just wondering, what is the burden of pancreatic inflammation right now at this time with the tissues that you see?
Yeah, so a lot of the pancreatic head was very socked down. There wasn't a ton of saponification, but certainly, any anastomosis would be pretty perilous. And one of the reasons why we decided against doing anything even remotely like a Whipple was not necessarily because of just, all the points you brought up, which are very valid, but also because by this point, all of his bowels were just so edematous that we thought that any anastomosis, let alone multiple anastomoses, were a setup for failure. So that's why we just went with wide drainage. So we sort of just put some momentum and some tissue on the pancreatic head there at the SMB junction. Where that was sort of just our Hail Mary procedure. Placed really wide drains, and we got out. Started him on TPN. He was actually doing okay. Brought him back on hospital day 7 for essentially a skin only closure. We did put a vicryl mesh bridge, but we weren't able to get the fascia together because it was so retracted. So he did have a primary skin closure. Over his hospital course, as with any major trauma, particularly with a pancreatic injury, he sort of had this smoldering low-grade cirrhosis and sepsis for a while, but he actually did fairly well. Did have an episode of bleeding for which he got an angiography for, and actually did have a splenic artery pseudoaneurysm that was coiled. Percutaneous sepsis drainage. This is all sort of kind of expected, as I'm sure you've all had patients like this too that sort of need these intermittent drainage procedures, things like that. Finally developed a walled off pancreatic collection here that you see, that we were able to put a cyst gastrostomy into endoscopically with the help of our GI folks. And I see a question, why did you start an enteric feeds on hospital day 71? Because he was doing well. He was doing well, so we started why didn't we start entire feeds? So we didn't in the beginning because you know, we just wanted to hold off and give him some bowel rest. Maybe we were overly conservative there. But you know, with all the drains and concern for leak, we sort of wanted to be a little more conservative. So he was on the TPN for a while. And then finally got skin grafted on his abdominal wound and was discharged home. I know we're pressed for time here, so I'm just gonna go through. He did come back on post-op day 277 in clinic with a ventral hernia, which we took him back to the operating room for a ventral hernia repair with an anterior component separation. And you can see here this picture of his abdominal wall with all of the drains out on post-injury day 640. And he's doing well. He's back to his normal activity, living his life without any drains, eating a diet. So that's all I have. Apologies for running a little bit over time.
Mike, just one point, and thank you so much for this case. This is like such an important case, excellent discussion. You know, the delayed pseudoaneurysms from the pancreatic leak is so important to really be proactive about as well, even before there is bleeding. But also, I don't know if you are all seeing this at your institutions, and I wonder if Dr. Namias is as well. I mean, we certainly did in Miami, but we're seeing delayed vascular injuries just from gunshot wounds themselves and all that. So hunting for the delayed pseudoaneurysms and stuff just in general, I think was great as well. But what an excellent case. Interesting. Sad about the drain eroding into the duodenum, but this is fantastic. What a great save. Thank you.
Thank you, Mike. Great case. Thanks again for our panelists and now the Pan American Society.
Thank you all very much.
Great. Thank you, Dr. Klein, for the presentation. Now we're going to start with the PTS case. I'm just going to do some very quick introductions. So our presenter from the PTS side is Dr. Juan David Perez. He's a PGY3 at Hospital das Clínicas, University of São Paulo. And we're having the three panelists with us today, Dr. Tanya Zachrisson from the University of Chicago, Professor of Surgery, Dr. Mary Crandall, Chair of Surgery from Metro Health, and also Dr. Ansar Mahmood. He's the president of the British Trauma Society. So we're very happy to have you all here for this session today. Dr. Juan, I think you may present your case and share your screen.
So thank you, Dr. Carlos. Just 1 second that I'm starting my presentation. Can you guys just confirm to me if it's already on for you?
Yeah, it is.
Perfect. So first things first, I would like to say good morning, good afternoon, and good night for everyone. I see that there are a couple of people all around the world. So right now in Brazil, it's 2:36 p.m. So we are starting our presentation. So I would like to thank Dr. Carlos and everyone that is here for the honor. I'm very, very pleased and very honored to present this case that we have operated here in Brazil. I will start my presentation actually showing this picture. This is the front entrance of the university, the school that we have here. And here we are going to show a couple of things about the things that, a couple insights about the things we perform when we are talking about surgery and trauma. So I'll start saying that I know I don't have any conflict of interest to disclose. And we are going to start with a man that is a 45-year-old man, actually. He had no previous medical problems or pathologies, and he was on non-use of any medication. He was actually admitted after attempt of robbery. He was the victim, and he got a gunshot wound over his right side thorax, okay? So on the pre-hospital care, what we have was a patient that was actually stable. His heart rate was 130, but his blood pressure was fine. His Glasgow coma scale was 15, and he did not receive any medications or fluids at all on the pre-hospital care. He arrived at our trauma center here at the Hospital das Clínicas of the University of São Paulo. Here we can see the picture, how our trauma bay is organized. You can see that our trauma is well equipped. We have a lot of things that we can use for the management for the trauma. So we do have ultrasound. We do have saline that are warmed by our stove. We have all the things that are necessary to take care of those patients. In this case, we started watching this patient. He was on our ways, he was taking oxygen by a non-brain inhalant mask, and he was doing fine. His O2 saturation was 99%. On his breathing, what we could see is that the sounds were diminished on the right side, and he had an extensive palpable emphysema on the subcutaneous on the right side. Besides that, what he had was a gunshot entrance on his right side over his second intercostal space. And we could see on the posterior way of the thorax that he had a large bullet on the back. So here we can see this picture, this illustration that I performed. You see the place where the projectile entered, his trajectory, and you can see where it was lodged. So going on the circulation, he was pretty much stable, only a little bit tachycardic. His extremities were warm, and he was a little bit diaphoretic, but he was stable. We tried to do a EFAST. The FAST was negative, but the EFAST was a little compromised especially because of the emphysema he has on the subcutaneous side, and his stability and his EZ was fine. So what we performed here for this patient was just stabilization, bringing lactate, and we then headed to the CT. Before I start with the CT, we can see his arterial blood analysis. This is a protocol that we have here. Most of the patients that are trauma victims, we start by taking arterial gasometry. And even though he was stable, as I mentioned before, we could see that this patient already showed us a couple of signs that his microperfusion was already in shock. So we can see that he has a rising lactate, and his base deficit was already -6.
So Dr. Juan, just can I hold you for a second? Just I'm going to ask for the panelists to make their comments in this section. And while they do that, just check your microphone. It seems that it's a little bit distance from where you are actually speaking. I don't know if you're using your cell phone or a headphone, but just make sure you're having the microphone close to your mouth as well. Okay, so Dr. Crandall, you have your hands up. What would you do in this case? Would you do something different?
I just wanted to make sure. I think of a chest X-ray or chest, abdomen, pelvis plane films as adjuncts to the primary survey in these patients, especially ones that come in with such a profound shock index of basically over 1, with a heart rate over 130 and a blood pressure of 120. So I wanted to see if that was part of your usual customary practice in the trauma bay as the adjuncts to the primary survey, because I don't like sending people to the Darwin chamber without that information. So.
Oh, sorry.
No, you can answer. Then I'm getting the other comments.
So it really depends on how the patient arrives and also how is the pre-hospital care. We do understand that this patient was in shock at this moment. So there is a lot of discussion, where is the best moment to start giving blood transfusion. But generally, these patients, we start the emergency department by taking arterial blood gas analysis, so we can see those parameters in the best way. I don't know if that's going to answer the question that you had, but usually we start Darwin chamber. I don't know what is the Darwin chamber. It's not usual here in Brazil, but yeah, that's it.
That sounded like a no chest X-ray and no abdominal X-ray for this guy.
Okay, so I got that question. The time that we take to perform an X-ray, like even a thorax or even like a chest X-ray, it's at least here a 30-minute window. It's easier to get a CT right now. So
did you say 30-minute window?
Yes. It's really hard to perform. I don't know why. This is a problem that we have here, and we already tried many times to change that. But for us here, the CT area is so close to the emergency department that it's gonna take maybe 10 seconds to take the patient out of the trauma bay and get it into the CT area. So it's pretty easy for us to get the CT, and that's even questionable because we do have patients that are in shock, but we are able, because of that moment, that gap, that window that we have that is so before, we are able to perform a CT scan and then go, for instance, to the operative room. So it's something that happens here. I do know that is not the best scenario, but we have to work with the resources we have.
Okay, so Dr. Tanya, you have your hands raised as well?
Yeah, thank you. And thank you, Juan. You know, a couple of things. It's just for any medical students or residents, you know, on the call, junior residents, it's, you know, it's tricky, Juan. I agree with you. This patient seems fine when they present. I think we need to be a bit careful. This is something we struggle with here also, is like the patient being pretty stable or saying things like that. Like it's a very binary thing. This patient is in class 2 hemorrhagic shock. This patient is not stable. Are we used to seeing patients with tachycardia only? Yes, we're actually used to seeing a lot of people that are hypotensive. You know, we don't get tachycardic when we see it because it's unfortunately so common, but I would just be careful about that. Also, I wonder, just with the non-rebreather mask, it's, you know, sometimes we get nervous in our trauma bay. I know I get nervous in the trauma bay because the patients can saturate well. The sats can be 99% or 100%, but if they're getting 10 liters of oxygen a minute, like I want to know if they're saturating that on room air. We use our non-rebreather masks only while we're getting ready to intubate. It's because there's no plan B after that. I can never send someone to CT on a non-rebreather. So I'm sure EMS put that on, but just for, you know, junior trainees or medical students in the audience, it's good to know what the saturations are like with that. And I love that you picked up a subcutaneous emphysema. In fact, even just picking it up on physical exam, especially if there's challenges with getting chest X-ray, you know, you saw that with the ultrasound. For us, that's like that's a pneumothorax until proven otherwise. So we would probably treat that with a chest tube. But just nitpicky little OCD, obsessive compulsive disorder things for me that we talk a lot about here locally. But thank you, Juan.
That's great. Dr. Mahmoud, do you have any comments?
No, I like the Darwin chamber comment, but I think likewise sometimes we have a preponderance to doing CT in the UK, and I think I explained the reason behind it, because we need a specific surgeon available. So if we head to theatre, 90% of what we call our code red trauma, actually usually we will spin them. We'll get them through the donut and get the CT scan done, just so we have the information as we're leaving for the OR. So we tend to scan early, but I think one of the things that we tend to do is, if you're worried about the chest here, we do thoracostomies quite early in these patients. So you do a thoracostomy, that tells you if blood's a problem versus air, and it just allows some rapid decision making. And then you can step in whichever direction you want to go in. We don't really have hybrid facilities in the UK. There's about 2 of the 24 adult major trauma centres in the UK that have a hybrid or OR type facility in the ER. We actually have to go to theatre, and for us, I heard, I think Dr. Zackerson saying that it's a 4-minute run. I mean, it's probably similar. We have to go up in an elevator and then across on a different floor, so it takes a few minutes, and that's always a little bit of a concern if you've got a shocked patient. But I mean, so far so good, I think, with this patient. We need a bit more information.
That's great.
Okay, so I'm gonna go ahead. Without further ado, I'm just gonna show the CT score, and it's quite funny to see how the environment ends up to give us the best way to guide this patient management. So for us, as I mentioned before, the CT is so close for us that it's just something that is quite regular and quite normal for us to just take the patient to the CT. And right now I'm gonna show you the CT. I hope it runs out. So we can see here that there is a lot of emphysema that starts on the neck area. It starts on the neck and goes all the way down to the chest wall and then even to the abdominal wall. And we see that there is a pneumothorax showing up for us. And we can see also here, but in the next that I'm going to show, there is a projectile that is lodged in the backside, as well as there is a small portion of the projectile that was stuck on the liver. Okay, so right now I'm going to show you the lung view, the lung window. So again, we see this huge emphysema on the right side that is actually showing us why the EFAS was not feasible. And we do see a huge pneumothorax, and as well as the pneumothorax that I mentioned before. So based on that, the patient remaining stable, he then came back to the trauma bay, and then we indicated the chest drainage. Here we have the picture of the patient being drained. And right after the drainage, this patient had 900 millimeters of just blood, actually. I wrote down hepatic fluid, but it was pretty much like blood in the less than first hour of the chest drainage. But the patient remained stable. We decided based on the first gasometry that we performed to give the transfusion based on the microperfusion parameters that we had. So he received 2 blood transfusions, but he was stable. And when I say stable, I'm saying heart rate and blood pressure at the whole time. There was no alteration of those parameters after or even before the blood transfusion. And now there's the question that I want to make is what to do next. What is the best management for this patient right now?
Great. Dr. Crandall, do you want to start with this one?
Sure. I imagine that there might be some unexpected findings later on in the slides, but this is a fairly traditional, it seems as though it was fairly traditional, isolated to the chest and right upper quadrant gunshot wound. So in our hands here, in our standard practice, this would be managed by tube thoracostomy drainage. And if it went on to have a retained hemothorax, or if it looked like the chest were not completely evacuated, then maybe an early VATS and early YATS to completely evacuate that space. For a right-sided gunshot wound with an obvious thoraco-abdominal transit, that is not something that I would go after, not something most of us would go after to repair the diaphragm or to drain in the non-bleeding patient. So this would essentially be done, presuming that you have evacuated the hemothorax and get good re-expansion of the lung.
Excellent. Dr. Tanya, any comments?
Totally agree with Dr. Crandall, what she's saying. Classic right-sided thoraco-abdominal gunshot wound. Something that's interesting here at the University of Chicago, where we're 40% penetrating. Sadly, our volume is now, we keep going up around like 1,000 a year for a whole bunch of factors I won't get into. Classic teaching, exactly what Dr. Crandall said. Normally, non-operative management, your patient is hemodynamically normal, no concern with that. We've been more and more aggressive, not intentionally, but just the clinical situation has dictated more and more aggressive approaches surgically. We're operating on these a lot more, Marie, just because we've been having like biliary leaks, these retained hemothoraces, liver biomas, and we find there's a category patient where you get the VATS, you get the IR drains and all that, and they're fine, but they spend like 2.5 weeks in a hospital. Other patients that are, questionable, you bring them to the OR, you suck out the chest, you put your chest tube in, you repair the diaphragm, you drain the liver, and they go home in like 2 days. And I don't know whether it's because of more hollow point bullets or the type of ballistics we're seeing with our gunshot wounds, but we're becoming more aggressive surgically, and our patients seem to do better, which is very counter to the guidelines in the literature. So it's something we need to look at and explore further, but I don't know if other centers are finding the same thing or doing the same thing. Thank you.
I think your point is really well taken with respect to the change in the type of missiles and the type of firearms that we're seeing injuries from. So back in the 90s, when I was in training, the number of injuries from high capacity magazines, from high velocity weapons had gone down to its lowest point in history with the Brady Bill. We really saw a lower proportion, probably only 5% of civilian gunshot wounds had that kind of destructive force, those kind of military grade weapons. I'm definitely seeing a lot more tissue damage, and it's been going up ever since the Brady Bill, ever since the ever since the politics of the sunsetting of various firearm control, the assault weapons ban, if you will, sunsetted, I definitely see higher injury burden. And I think that is possible, likely that you're starting to see more parenchymal liver destruction, these right upper quadrant gunshot wounds. You may see more bio leaks, and it has not yet progressed to the point that we are rewriting our guidelines based on it. I think that there are many patients with, small firearm injuries that can absolutely don't need surgery. And if you have the patient with a big old blast hole right through his liver, then that is the one that may need something more aggressive. So I think that's a point really, really well taken, really important.
Nice. Mr. Mahmoud, would you consider operating this patient, maybe because of the amount of fluid that's coming out from the drain, or would you head to conservative management as well?
Again, if the patient is stabilizing, I think I heard somebody saying earlier that you monitor. We do the same every 20 minutes. Do a gas, check the position, and if the shock indexes are improving, then I think I'd agree that rushing in isn't going to achieve very much, and that's certainly the case in the UK management anyway. To some extent, we probably are more conservative than we should be. So we are learning some of those lessons and probably are overly conservative. But at the same time, as I said, this is with a slant that penetrating trauma like this is relatively uncommon. Most of our penetrating trauma in the UK, in the inner city centres where it's 20% of our trauma load is penetrating, actually 85% of that to 90% is usually knife crime. It's knife crime rather than ballistic injuries. So with that slant, we tend to be quite conservative. If we don't have to rush in, we don't rush in.
Excellent. Great points. Dr. Juan, I think you can continue.
So after this amazing discussion over operative and non-operative, what I can say is that we indicated the operative way. So the proposition here was doing an exploratory laparoscopy as well as a thoracoscopy axis. So we first started with the abdominal axis. Here you can see that the surgeon standed in the middle of the legs. And we started by placing an umbilical port as well as an epigastrium port and a right hypochondrium, a little bit close to what we use when we are performing the cholecystectomies, the laparoscopic cholecystectomies. So here we can appreciate the abdominal cavity. You see that there is no any blood, only a little bit of blood being collected really close to the subdiaphragmatic space. We then placed the first trocar, actually the second trocar on the epigastrium, an 11 millimeter trocar. You are gonna see that there is a abnormality of the chest wall of this patient that was quite interesting, and it did change all the decisions that we made. So this patient had something like a pectus scavatum, but not completely on the upper weight of the chest, but just on the base. So you can see here that he has one of his ribs that is a little bit to the inside. So we started by taking out the great omentum, and after gently going, pushing the liver down, we can see that there is a little bit of blood accumulated on the subdiaphragmatic space, but it's just a little bit. And you can see that there are a little bit of tissue adhesion close to what we can see that is a small hole on the diaphragm up there. So here I can show you how hard it was, the structure, as I mentioned before. So going ahead, we then placed the third trocar, actually a 5 millimeter trocar that was really close to the gallbladder point. And with that, we were able to manipulate the liver and start doing the aspiration of the blood that was accumulated. So we can see here that after we were able to push the liver down, we can aspirate that blood. And if you can see, the right hand is a little bit compromised because of that chest wall alteration. And that's really important because that's going to guide us the next procedures that we are going to make. So we were able to take out all those adhesions. And after taking those out, we were able to see all the amount of the density of the lesion. So we can see here less than a centimeter perforation of the diaphragm. And you can see some scoriations over the wall, the peritoneum, and a little bit of clot, like blood clot. And there was a small hematoma on the liver, but with no active bleeding. So we assumed that it was not necessary, any treatment of the liver was necessary in that case. So we did perform a lot of washing, so with warm saline, to be able to see if there was any active bleeding. We kept washing until we could see all the lesion, all the scoriations that there were there. And one more time, you can appreciate this small hole, small projectile trajectory that was on the diaphragm, a little bit less than 1 centimeter, that we consider the non-imperative way on that case to suture the diaphragm. So after doing that, we then headed to the thoracic moment. This patient was already drained, as I mentioned before. He had a chest tube. So we first took it out. That's the yellow point. We took it out, then we washed the whole thoracic cavity, because when we first tried to put the optic, we were not able to see anything because there was a lot of blood. And after we made that, we were able to see all the thoracic cavity. So here we just started our thoracoscopic axis. You can see that we were able to see the whole cavity by hypoinsufflating the lung and also using a little bit of CO2 on that case. You can see that there is a hematoma clog that is going on there, and you could also see some atelectacy going on. So we then placed a second trocar that I showed you before. That's gonna be on the mid axillary. Actually, it was on the hemiclavicular line, and we started washing all these clots and washing all the hematoma that was present there. So we did wash almost with 3-4 liters of saline. Then we switched the places. So we introduced the optic on the second trocar and kept washing. Here you can see on this image, it's quite well demonstrated. One of the main landmarks, anatomic landmarks, that is going to be the arch of the hemiazygos, the azygos system on the right side. Maybe this video or the next one. There are so many videos, but you're gonna see what I'm talking about right up next. There you go. So you can see the arch of the azygos going on. And to finish, we then placed a chest tube directly posteriorly and superiorly. It was a little bit fogged, so you're not able to see so well, but it was already drained. And to prevent any fistula, any biliary leakage, we also did insert abdominal drain that was placed on the infradiaphragmatic space. So surgery time, 90 minutes. This patient went well, did not receive any blood transfusion after all, no need of the vasoactive drugs, and he was discharged to the general ward. So here, first operative day, he was doing fine. We did start the chemoprophylaxis for thrombosis. The third post-operative day, he was with no need of oxygen supplementation or any drugs at all for pain. And you can see here on the x-ray on the second day, post-operative day, it was getting better. On his fourth post-operative day, this patient had a worsening of his X-ray, so we decided to take a CT scan, and you can see that the emphysema got a lot smaller than it was before, and there was no hemothorax left, and just a little bit of pneumothorax. But in general, we can say that the result was really great compared to what it was when he first arrived. Okay. So 6 post-operative day, this patient had his abdominal drain removed. Then on the 7th post-operative day, this patient had the chest drain removed. And what we can see here is the X-ray, the control X-ray, just before his hospital discharge. this patient is going pretty well right now. He came back a couple days ago with no intercurrences or actually an eventful post-operative time. Okay, so I'm gonna open my space for questions, and I would like to say I'm very pleased and thank you very much for all the attention and the opportunity to be here. Okay.
That's awesome. Thank you, Dr. Juan. So we could stay here for hours discussing important aspects of both cases, actually. But in the interest of time, I'm going to ask for the panelists to make their final comments and anything that we can move on with this meeting. So, Dr. Tania.
Juan, thank you so much. That was such a fascinating case, and we really, really appreciate the videos. It really is, it's great to see. So, muito obrigado a você for that. I was wondering, for this case, did you have what kind of conversations you might have had around closure of the diaphragm intraoperatively or not? But thank you so much for an exquisite case and beautifully presented. And I hope one day I can speak Portuguese as well as you speak English. So thank you.
I love your Portuguese. It was just great.
Awesome. Dr. Mahmoud, Mr. Mahmoud?
Yeah, I mean, as I said, I think our preference would have probably been conservative, but then our thoracic surgeons would say, they see whatever a 10% or 15% empyema rate, which is more difficult to deal with downstream. So if you have the skills to do a quick VATS process and eliminate a problem, a small hole in the diaphragm, I think I would have left it, and that's what we usually do. We don't worry about it. Again, if it's a problem in the future, which again, I run the major trauma clinic, so that's the sort of other context I'd have here, which means that all of these patients come back to the clinic that I run. So I see their abdominal problems and their limb problems and their neurology and their chest issues because they all come through the clinic. It's a multidisciplinary clinic, and we have to run it that way because, as I said, we don't have a single system trauma surgeon. So we try and have a one-stop shop. Otherwise, these guys come back to foot and ankle clinic, pelvic clinic, spinal clinic, etc., 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 and it becomes hugely burdensome for the patient and the system. So we bring them to one clinic, and we try and bring the clinicians to that clinic. But I think, yeah, well managed. I don't have any objections to the way you managed it. As I said, we may not have done the same thing, but I think it was well managed and you've had a good outcome. And what is interesting is, I don't know, in your units, do you have any guidelines around when to take out a chest drain? That's something that there is no agreement in the UK. Do you accept a certain amount of drainage? Do you, as long as the lung is up, if it's draining 200, 300, 400 mils a day, do you leave it or take it out? I'd be interested to hear from the panel what they think of that, because my own has become more and more, maybe aggressive is the right word, I don't know what the right word is, but I take them out quickly. I tend to take chest drains out quickly. Once the lung is up and there's no air leak anymore, the chest copes with the effusions. They disappear quite quickly, with or without the chest drain. And my own thoughts are, as somebody who does we do a reasonable amount of rib fixation for flailed chest, etc. I've learned that I take the drains out quite quickly, and when I see them days or weeks later, rarely a problem. So I think we're probably too conservative with chest drain removal, but there's just one thought. Thank you.
I love that you brought that up, Dr. Mahmoud, Mr. Mahmoud. And I also liked your comments in the chat that you're not so fussed about it. Yeah. I love that. And you're right. That is definitely in the location of the art versus the science of surgery. There's no great evidence-based protocols for these. There's no actual guidelines that I'm aware of that are based on output, in the exception of the elective thoracic surgical practice, where it's very clear that we can start taking them out if they're 250, 300. My personal practice is not that. My personal practice is if it's less than about 1 to 2 cc's per kilo per day. So in that neighborhood of 100 to 150 cc's for most patients. I say ideal body weight because of course we're in the US, so we're bigger than the rest of the world. But that is my practice, and my thought has been that we see a higher risk of things like empyemas and retained hemothoraces with non-elective traumatic injuries to the chest than we do elective surgery. So I like to make sure all that fibrinous gunk is really truly evacuated. But I may be wrong, and I would look forward to evidence-based guidelines to let me take them out sooner.
That's great.
Just to, Carlos, just to interrupt you, I know in the interest of time, Mr. Mahmoud, thank you for that question. We always teach like less than 100 cc's in 24 hours. And there are actually some nice studies, Marie, from Lou Pisano, Dr. Pisano at the University of Miami years ago. He talked about you can, discontinue chest tubes both in critical care units and on the floor after 3 hours or 4 hours. But I think the key question is, why did I put the chest tube in the first place? Is it for a pneumothorax? Is it for a hemothorax? Or is it for a combination? And so I'm going to be looking at the bronchopleural fistula. Is there an air leak? And the serous rubbing of the chest tube against the pleural membrane doesn't really bother me so much. So maybe at 200 cc's in 24 hours is like less, doesn't bother me as much. If it's for frank blood, I think my question becomes, within 72 hours, does this patient need an early VATS, like a VATS or not? And VATS by definition should be early. So I think those are kind of the questions we sort of think about, but I think it's an excellent question for us to ponder as a society of trauma surgeons. Thank you.
Yeah, definitely. Okay, so thank you very much for your participation. We're ending the meeting with a little bit late, but Dr. Juan, thank you very much for your presentation. Dr. Tanya, Mr. Mahmoud, and Dr. Crandall, thank you very much for being the panelists for this meeting. Thank you, Dr. Klein and Dr. Vandip for running the AAST side of the session. And we look forward to have you here once again next Monday for the meetings of the PTS, and next month for another session of the AAST and PTS meeting. Thank you very much. Bye-bye.
Bye.
Thank you. Thanks for the invitation.
Thank you, Carlos. Thank you for everything as well.
Yes.
Bye, everyone. Thank you.
Thank you. Bye-bye.
Thanks all. Bye.